Hi guys, welcome back to the Pharmacology series. My name is Dr. Wallace, and today we're going to be continuing talking about mental health, specifically about antipsychotics. Schizophrenia occurs in about 1% of the population. Schizophrenia is a type of chronic psychosis that involves both positive and negative symptoms. The positive symptoms refer to things that are there that shouldn't be, so like extra symptoms that the person has. These include things like delusions, hallucinations, which are typically auditory. Very frequently, patients will hear voices that aren't there, as well as disturbances in thought and cognition and speech. There are also negative symptoms, however, though. Negative symptoms are things that should be there but aren't. So it's like a lack of something. Common negative symptoms include things like a blunted affect as well as apathy. The onset for schizophrenia is frequently the late teens to early adulthood. So that period of time where the person really changes and starts to take a lot of responsibility for themselves and starts to be responsible for all of the, kind of daily things that you need to do to be successful in life, whether it's self-care, managing a household, going off to college for the first time, or going out into the workforce. It's at that period of time where the person really becomes responsible for themselves, where we start to see the symptoms of schizophrenia present. There is a strong genetic component that we see with schizophrenia. And we know that when we look at the pathophysiology of the disease, it is associated with with an imbalance in dopaminergic neuronal pathways in the brain. So we'll see that a lot of the drugs that we have affect those dopaminergic pathways. We'll also see drugs that affect serotonin as well. But dopamine is kind of a mainstay of most treatment, especially traditional treatment for schizophrenia. When we talk about antipsychotic drugs, there are two different kind of classes of antipsychotic drugs. There are first generation and second generation drugs. First generation drugs are the typical antipsychotics, are older agents, and then second generation drugs are atypical antipsychotics. These are generally newer agents that can have less worrisome side effect profiles. Antipsychotics are used for multiple different manic and psychotic states, and they are the primary medication that we rely on to treat schizophrenia. Now, there's kind of a trade-off with antipsychotic drugs because they are associated with very serious adverse drug effects. They provide benefit. They do provide some benefit, but again, there's these serious adverse drug effects that can be severe and can be permanent. When we talk about these serious, possibly permanent adverse drug effects, our really big concern here is our movement disorders, specifically EPS, extrapyramidal symptoms, which we'll talk about them in a second. But these can be really severe. They can progress to tardive dyskinesia, and again, can be permanent. So there's this big trade-off between treating with antipsychotics and managing the possibility of adverse drug effects. Also, when we look at using antipsychotics are not curative. We don't have a cure for schizophrenia. They lessen the symptoms and they can allow the patient to live a much more productive, normal, if you will, life, but they're not curative. And along with antipsychotics, there needs to be intense non-pharmacologic therapy. You cannot just throw antipsychotics at a patient and expect that to be enough. It is not. There has to be a lot of, cognitive behavioral therapy, environmental assistance. There's got to be really close following of the patient in addition to the antipsychotics. Again, antipsychotic drugs are divided into first generation and second generation agents, which we will talk through what this means. But then the first generation agents, or kind of our older typical antipsychotics, are then further divided into low potency and high potency. Now, low potency, high potency, that's not describing their efficacy. That doesn't mean like low efficacy, high efficacy. Low potency and high potency rather are describing the affinity for the D2 dopamine receptor. So low potency, low binding affinity, high potency is high binding affinity for the receptor. Now again, this doesn't necessarily tell us how effective it's going to be, but it really does affect the adverse drug effect profile. So we'll see the importance of this when we look at the actual drugs themselves. The first generation antipsychotics, again, are the older agents. These are the first antipsychotics that we had. Because of that, we call them typical antipsychotics. The typical antipsychotics or first generation agents you see listed down here in the bottom. Again, we divide these into low potency and high potency. The first two that you see here, chlorpromazine and thioridazine, these are low potency agents, meaning they have a low binding affinity for the D2 receptor, which is where they work. The other agents that you see are high potency agents, meaning they bind with high affinity to the D2 receptor, the dopamine receptor. I've bolded the ones that are used the most commonly. So the most commonly used low potency agent is chlorpromazine. The most commonly used high potency agents are flufenazine, haloperidol, which is called Haldol. Sometimes you hear Haldol like said clinically more than haloperidol. Prochlorperazine is another one that's used relatively commonly. Now, when we look at the first generation antipsychotics, their antipsychotic action is due to their binding to the D2 receptor and blocking it. So they are antagonists at the D2 dopamine receptor. Now, again, schizophrenia, psychosis, is associated with increased dopamine in specific areas of the brain. That's what causes these positive symptoms of schizophrenia, like hallucinations. So we want to block some of that action of dopamine. And that's what these first generation antipsychotics do. You can see here, right, that schizophrenia is associated with a lot of dopamine released in the brain. And the antipsychotic drugs work by binding to the dopamine receptor and doing nothing. Right, so it blocks that dopamine receptor. So there's decreased actual binding of dopamine. Now, these typical antipsychotics also bind to various other receptors, and different agents bind to different receptors with different affinities. Hence, there's like different side effect profiles with each of them, but they bind to a ton of different receptors. They block muscarinic receptors. They block alpha receptors, serotonin receptors. They block H1 histamine receptors, which is why they cause so much sedation. So there's a lot of other effects that are going to be associated with these drugs because of the binding to so many diverse receptors. When we look at typical antipsychotics, they are generally not first-line therapy. And the reason for that is that they have a very high incidence of extrapyramidal symptoms. So they have a very high incidence of movement disorders. And again, these movement disorders will develop, according to dose and time. So the longer you take these agents, the more likely you are to develop movement disorders, and the more severe the movement disorder, and eventually it becomes permanent. So we don't use these until we have to, right? Once we absolutely have to, or if it's just in an acute situation like Haldol to calm a patient down acutely. When we look at the incidence of EPS, there's an increased incidence with drugs that bind strongly to the D2 receptor. So, for example, there's much more movement disorder symptoms, or EPS, that occur with haloperidol than there is with chlorpromazine, because haloperidol binds to that D2 receptor much stronger. So it's associated with more EPS than a low affinity drug like chlorpromazine. When we talk about antipsychotic efficacy, equal efficacy can be reached amongst this class. So there's not any studies that show, that one of these is just always going to work way better than the other. It's very patient specific. And when we choose an antipsychotic, it's very much based on the side effect profile of that specific drug and the specific patient that you're dealing with. And then again, their history. What have they tried? What works for them? What doesn't? Although, like in general, we can say that we're not going to start with a first generation agent. The first generation agent will typically come later. Second generation antipsychotics are the newer agents. These are what we call atypical antipsychotics. These are the newer ones that are a little bit different than those old antipsychotics. These are first line for schizophrenia. Okay, so these are the agents that we're going to start a patient on when they're first diagnosed with schizophrenia. We do also use them for various other conditions, and we'll talk about those in a minute. We'll get to that momentarily. I said that schizophrenia is associated with too much dopamine activity in the brain, and then there's also some serotonin component as well. The typical agents work just by blocking dopamine. The atypical antipsychotics, though, work, their antipsychotic action is due to both dopamine blockage and serotonin receptor blockage, or serotonin receptor antagonism. Now, we've known for a long time that overactivity of dopamine, or too much dopamine in the brain, is associated with schizophrenia. But now there's research and there's evidence that there's some specific serotonin receptor activity that's also associated with psychosis. So, for example, the serotonin 2A receptor is stimulated or associated with the hallucinogenic properties of LSD and hallucinogenic mushrooms. So those drugs, those chemicals or compounds cause hallucinations by stimulating this serotonin 2A receptor. So we know that there's some connection there. And then we see that these second generation drugs that block both dopamine and serotonin receptors give us these antipsychotic effects. They also block various other receptors to differing degrees. So different drugs kind of affect different receptors, so they have different adverse drug effect profiles. But there's some muscarinic binding blocking. There's some, alpha receptor antagonism. There's some histamine receptor antagonism. So we do see a lot of kind of varied effects from these agents as well. Again, these second generation antipsychotics are first line for schizophrenia. We see aripiprazole used a lot. We see olanzapine, quetiapine, risperidone, all used very commonly. And the reason that these agents are now first line for schizophrenia is because they have equal or improved efficacy. So we used to think that the first line agents work way better, but their side effects are just too bad. But now we're starting to see that we can achieve the same efficacy with these atypical antipsychotics. And then the major benefit is that they have way fewer EPS. Now, the reason that they have these decreased EPS or decreased association with movement disorders is because the atypical agents don't rely solely on dopamine antagonism. They work with some dopamine antagonism and then some serotonin antagonism as well. And there are some agents that actually don't even affect dopamine. We'll get to like the specifics as we go. But because it's this mixed effect, we don't have so much emphasis on the dopamine antagonism. So there's less of a movement response, right? Or less adverse drug effects when we look at movement. Now, there is a trade-off here. We have decreased EPS, but these second generation agents do have an increased incidence of metabolic adverse drug effects. Now, we do see things like diabetes. We see hypercholesterolemia, so I'll just say increased cholesterol. We see weight gain, sometimes severe weight gain. So there is a trade-off. But the thing is, these things, the increased cholesterol, the weight gain, the diabetes, they're much more easily managed. And they're not causing these permanent irreversible effects where once, a patient progresses to tardive dyskinesia, that's extremely damaging to quality of life. So we prefer these second generation agents. Now, when we're choosing between atypical antipsychotics, the choice between different agents is guided by patient response and comorbid conditions. Just like I said a couple minutes ago, we'll see that different agents are associated with, different adverse effect profiles based on the specific binding affinity that they have at all of these different types of receptors. So you look at your specific patient, you look at the drug profile, and you say which one is best for this patient. You might have a patient that absolutely does not want weight gain. Okay, well, that will guide your decision-making process. The only caveat here, or thing to remember, is that clozapine is never first line. You cannot use clozapine as a first line agent. It is reserved for refractory patients only. So about 10 to 20% of patients are not going to have an adequate response to first generation or second generation drugs. Okay, so you would start someone on a second generation agent, right? Maybe you try a couple of them. Okay, if they don't respond, then you can try a first generation agent. If they still don't respond, you would say that this person is refractory, they're treatment refractory. In that case, you can give clozapine. Clozapine usually works really well in these patients. Now, why don't we just start everybody on clozapine if it works so well? The reason for that is it's associated with very severe adverse drug effects. So it's very effective, but it's got really severe adverse drug effects that really limit its use. We only use it when we absolutely have to. For example, it causes bone marrow suppression, seizures. There are cardiovascular effects, like, for example, it causes orthostasis. And because of this bone marrow suppression, and because of all of the changes in blood cell counts, there's a big risk for really severe agranulocytosis. It requires very frequent monitoring of white blood cell counts. Okay, so this is really serious stuff, and it's not rare. It's commonly associated with really serious adverse drug effects. So we hold back and we only use it when we absolutely have to. Okay, so we've had kind of an introduction to antipsychotic agents. Now we're going to talk through all of the details with mechanism of action and adverse drug effects. The mechanism of action of antipsychotic agents that we use in, for example, schizophrenia and other psychoses work based on blocking dopamine receptors as well as serotonin receptors. Okay, so the mechanism of action for the antipsychotic effect is dopamine and or serotonin antagonism. All first-generation agents work by blocking the D2 dopamine receptors. Most second-generation agents have some blockage of D2 dopamine receptors. Now remember, this blocking of D2 receptors is also what causes EPS, right, or the movement adverse drug effects. Most second-generation agents also block serotonin receptors. Now, again, the second-generation agents, because they have the serotonin activity, they have much less affinity for dopamine receptors. So second-generation agents have less affinity or no binding at all to dopamine receptors. That's why they have fewer EPS. So some examples here. These are just talking through some of the second-generation agents to look at their specific binding to see, you know, oh, okay, they have really low affinity for D2, or they are only partial agonists at D2, or they don't bind to D2. So clozapine. Clozapine is a second-generation agent that has a high affinity for D1 and D4, as well as serotonin, muscarinic, and alpha receptors, but it has a low affinity for the D2 receptor, so low EPS. Risperidone and olanzapine, these are other atypical antipsychotics. They antagonize serotonin receptor much more than they antagonize the D2 receptor. Aripiprazole and brexpiprazole, these are only partial agonists at D2, and then they're serotonin 1 and 2 antagonists. Now that might sound weird. You're saying, wait, we're supposed to be blocking dopamine receptors. This is agonist, but notice partial agonist. Remember, a partial agonist is kind of like an antagonist, right? If you think about it, I have my presynaptic neuron and then my postsynaptic neuron. And I have all of these receptors, right? And normally what happens is dopamine is released, it binds, and then it has some sort of an effect. Say it has an effect that's, you know, that big. Well, if I have this drug that's a partial agonist, my drug is going to come and bind. And because it's a partial agonist, it only induces this little bitty effect. And while it's binding, it's blocking the actual dopamine from binding. So now you're preventing this big effect from dopamine. So yeah, it's an agonist. It's causing a little bit of a stimulation, but that little bit of a stimulation is much smaller than what dopamine would do, and you're blocking the dopamine from binding. So in effect, even though this is a partial agonist, it's decreasing the activity of the endogenous dopamine that would be there. Pimavanserin. Pimavanserin has no dopamine activity at all. It has no affinity for dopamine receptors. All of its effect, so its efficacy, is due to serotonin binding. Now, this makes pimavanserin good at treating psychosis that's associated with Parkinson's. So this is for psychosis with Parkinson's. Parkinson's is also associated with dopamine, right? Remember, schizophrenia and Parkinson's are kind of like opposites. Schizophrenia is too much dopamine. Parkinson's is not enough dopamine. So if somebody has Parkinson's disease, we don't want to give them something that's going to further block dopamine. But sometimes there's psychosis associated with Parkinson's. So we need some way to treat that psychosis without worsening the Parkinson's. Pimavanserin allows us to do that because it treats psychosis from the serotonin aspect without influencing the dopamine aspect. These antipsychotic agents have multiple different uses. Antipsychotic drugs are the only approved drugs for the treatment of schizophrenia. So they are our main bag of tricks for schizophrenia, in addition to non-pharmacologic therapy and support. They their best kind of action that they do in schizophrenia is to decrease hallucinations and delusions, to decrease these positive symptoms. Now, negative symptoms can actually respond somewhat as well. So negative symptoms like flat affect, apathy, respond somewhat to the second generation agents. We do see that agents that have serotonin 2A blocking activity tend to be more effective in patients that are resistant to the traditional agents. And again, we used to think like that these first generation agents were really, really great, but we just couldn't use them because of the movement disorders. But when you look here, this is showing you relapse rates for patients, and it's comparing risperidone, which is an atypical agent, to haloperidol, which is a typical agent. And this over here in the vertical axis is the percent of patients that are relapse-free. So the patients that are successful, that haven't relapsed. And of course, it starts up here at 100, where all of the patients are successful. And then you see haloperidol, patients kind of start to drop off, and the number of patients who are relapse-free goes down. And then you see risperidone. So more patients are relapse-free with risperidone than with haloperidol. Okay, so this is showing us atypical antipsychotic agents can have even better efficacy than some of the typical agents. Now, there are long-acting injectable formulations that are available, and these are really helpful to improve outpatient compliance. There are multiple different formulations of long-acting injectable antipsychotics, and they can range anywhere from a duration of action of 2 weeks all the way up to some agents that last 12 weeks. This is very helpful because compliance is a big issue, and for numerous reasons. One, side effects. A lot of patients will self-discontinue therapy because of the side effects like weight gain or sexual dysfunction. Also, if a patient is not quite at optimal therapy, the disease itself, the delusions and the voices and the thought process that's part of the disease can actually convince them to stop taking the medicine, right? That the medicine's not needed, it's not good, they're trying to, poison you or whatever. So then they could stop taking the medicine, and then of course that episode just flares in a huge way and they go into a complete psychotic episode. So compliance is really important. Hence, when someone's outpatient, if they come into the office every 2 weeks or every 4 weeks and you give them a long-acting injection, they're getting the medication. So that's really beneficial. Patients who have experienced 2 or more psychotic episodes are most likely going to require long-term maintenance therapy. This is not the kind of thing where you just stabilize them and then take away the medicine and everything's fine. They typically will need therapy for at least 5 years, but a lot of recommendations now say indefinitely. Antipsychotics can also be used in the prevention of nausea and vomiting, which, remember, does involve dopamine receptors in the brain. First generation agents that really have a strong affinity for that D2 receptor are used. Typically, prochlorperazine is used. Haloperidol can also be used, though. To prevent chemo-induced nausea and vomiting, or any type of chemical-induced nausea and vomiting. Again, the way that they work is they block D2 receptors in the chemoreceptor trigger zone in the brain. So this would not work for other types of nausea and vomiting that aren't utilizing or aren't being stimulated from the chemoreceptor trigger zone. So like motion sickness, for example, this wouldn't be effective for. It's only things that are stimulating the chemoreceptor trigger zone, hence chemo-induced nausea and vomiting. Also, we wouldn't use the atypical agents for this that are not binding strongly to the dopamine 2 receptor. So we're only going to be using agents that really have a high affinity for the D2 receptor. There are numerous other situations where antipsychotic drugs can be used. And some of this is just because the kind of agitation and psychotic type symptoms can be present in lots of different situations. And then some of it is because they just bind to so many different receptors. We can utilize that. Antipsychotics can be used as tranquilizers to manage agitation. So like in patients who are just disruptive in the hospital and they can't be calmed down, we can give a antipsychotic agent to just essentially sedate them. Haloperidol or Haldol is used for this a lot in the hospital. Also, risperidone and aripiprazole, which are atypical agents, are approved for disruptive behavior and irritability that's associated with autism. Chlorpromazine is used for intractable hiccups. Pimozide is primarily indicated for the tics, both vocal tics as well as motor tics that are associated with Tourette's disorder. Tourette's disorder, we used to call it Tourette syndrome, is associated with multiple different types of tics. It can be, repetition of the same word over and over and over. Frequently, it's something that is socially inappropriate, but they can't control the fact that they're saying it. There are also all different types of motor tics. So there can be like small facial tics, flaring of the nostrils, for example, or there can be actual, large tics where it's an actual whole limb moving, for example. So Pimozide is primarily indicated for these tics, but we do also use risperidone and haloperidol or Haldol in Tourette syndrome as well, Tourette's disorder as well. Paliperidone is approved for schizoaffective disorder, which is related to schizophrenia. Lurasidone and quetiapine or Seroquel, quetiapine, are both indicated for bipolar depression. Many agents are used for the manic symptoms that are associated with bipolar disorder. And then some agents are used adjunctively with antidepressants for refractory depression. So typically for refractory depression, we will add aripiprazole, brexpiprazole, or quetiapine. And again, this is added to the antidepressant. It doesn't replace the antidepressant. Adverse drug effects are a really big deal with antipsychotic agents. There are some adverse drug effects that occur in all patients, virtually all patients. And these adverse drug effects are significant in 80% of patients. That's a really big deal. So there's a really big burden to the patient, and that's something that's important for you to understand, because again, there's resistance in patients to take antipsychotic agents a lot of the time, and there's psychological reasons for that resistance, but then there's also just they suck to take. So think about that. Keep that in mind, when you're pushing a drug on a patient, that you need to spend the time to pick the agent that works best for your patient, to try and listen and understand, what side effects are they most concerned about, and how can we try and alleviate those to make this therapy as painless as possible. Extrapyramidal effects, again, are like movement disorders, movement adverse drug effects that occur commonly with antipsychotic drugs, especially with the typical first-generation antipsychotic agents. Now, real quick, let's just look at or recall normal physiology of muscle movement in the brain. In the striatum, there's a balance between dopaminergic neurons and cholinergic neurons, right? And there's got to be a balance between the two. The dopaminergic neurons have an inhibitory effect in the striatum, and the cholinergic neurons have a stimulatory effect. If those are in balance, everything is okay. If those are out of balance, then we start to see movement disorders or movement symptoms occur. Now, when we talk about antipsychotics, antipsychotics are blocking dopamine. So now we're taking away that inhibitory effect of dopamine. And that means that there's a relative excess of cholinergic activity. So there's too much of that stimulatory cholinergic activity. And this gives us our extrapyramidal motor effects. Now, these motor effects, again, I told you guys, are dose dependent and time dependent. So as doses increase, we see the symptoms increase. As time progresses, we see the symptoms progress and get worse and worse and worse. Dystonias are like just little involuntary contractions, almost like kind of twitches, if you will. These dystonias appear almost immediately. So within like hours to days of treatment, you can start to see really mild motor symptoms occur. Akathisias, which are like this have to move feeling, right? Like this restlessness inside you, kind of, that makes your body move, occur in days to weeks. So you kind of progress into these akathisias. Parkinson-like symptoms, so like bradykinesia, rigidity, these tremor, these occur in weeks to months. Okay, so we're getting worse and worse and worse. And then that can progress to tardive dyskinesia, which we'll look at tardive dyskinesia in more detail on the next slide. But tardive dyskinesia is serious. It is a serious movement disorder that's associated with relatively constant, tics and movements. And this may be irreversible. So, you might be able to catch this and remove the drug, and symptoms might dissipate, but they might not. It's possible to cause permanent damage and these permanent disorders because of, higher dose, long period of time antipsychotic use with the first generation agents. Now, agents that have both anticholinergic and antidopaminergic effects limit the EPS. That makes sense, right? Because remember, the problem here was that we screwed up this balance. We need a balance of dopaminergic and cholinergic neurons. If we decrease dopaminergic and then we also decrease cholinergic, we're back to balance, right? We just brought the whole thing down, but they're still balanced. So that helps to limit those extrapyramidal effects. We can also achieve that balance by adding an anticholinergic agent. So if you have a patient on Haldol, for example, right, or haloperidol, and you're blocking dopamine, we can add something to therapy that would block the cholinergic neurons to add that balance. So benzotropine, for example, benzotropine can be added to therapy to kind of decrease that. But keep in mind, then you're adding anticholinergic adverse drug effects, right? So you're fixing the motor thing, but then you're adding, dry mouth and urinary retention and all of those other side effects that come with an anticholinergic agent. Akathisias respond well or respond better to a beta blocker like propranolol is used, or benzodiazepines, which we'll talk about in part 3 of the lecture. Other adverse drug effects that are possible with antipsychotics, we've already mentioned tardive dyskinesia, but tardive dyskinesia is a very serious movement disorder that can result from long-term antipsychotic therapy, more likely with the first generation or typical antipsychotics, and then again, more likely with the high potency agents, like haloperidol, for example. Tardive dyskinesia, is associated with involuntary movements, including bilateral facial and jaw movements. So often like kind of like a chewing motion with the jaw, and what we call fly catching movements of the tongue. So fly catching, like protruding the tongue, right? Like a frog catches flies. It's kind of a mean way to say it, but that gives you an idea of what it looks like. So like opening of the jaw, like chewing motion, lips curling, and tongue sticking out repetitively. Sometimes a prolonged holiday from therapy can lead to symptom improvement. So it is possible to stop the antipsychotic therapy for a prolonged period of time, and then symptoms can improve, and you can, very carefully progress with antipsychotic therapy. However, it's not necessarily or not guaranteed to improve. It is possible that the tardive dyskinesia can be permanent, and it is very debilitating. Antipsychotic agents can also cause NMS, neuroleptic malignant syndrome. Neuroleptic malignant syndrome is a potentially fatal reaction to antipsychotics. So it is very, very serious and does require emergent supportive measures. It can also be caused, or some people can experience NMS with general anesthesia. So it's this overall systemic reaction that happens in some people when they're given antipsychotics, but it's associated with muscle rigidity, fever, altered mental status, unstable blood pressure, myoglobinemia, and it requires a prompt, immediate discontinuation of the antipsychotic, and then supportive measures to, control the fever, maintain blood pressure, cause muscle relaxation if possible. We can, in addition to supportive measures, there are a couple drugs that can be given to help. Dantrolene is a muscle relaxant. And bromocriptine. Bromocriptine is a dopamine agonist. In this case, the NMS is associated with an antipsychotic that's blocking dopamine. So we administer a dopamine agonist in hopes to kind of reverse some of those effects. There are various other adverse drug effects that occur, lots of them, and they do kind of vary with different agents, but remember we said that they bind to tons of different receptors, so there's a lot of different stuff that can occur. So anticholinergic effects occur, so dry mouth, urinary retention, so caution with BPH, blurry vision because you block that accommodation process, constipation, often decreased blood pressure and orthostatic hypotension because of the alpha blockade. So again, caution in patients who are already on drugs that cause orthostatic hypotension. Caution in elderly who might be at an increased risk from falls related to orthostatic hypotension. Sedation and confusion. Thermoregulatory disturbances are possible. There are numerous different sexual type side effects that are possible, from amenorrhea to galactorrhea, gynecomastia in men, infertility, erectile dysfunction, changes in libido as well, significant weight gain, as well as glucose disturbances and lipid disturbances are possible. Weight gain is the most common reason, or one of the most common reasons, for non-adherence to medications. So weight gain might seem like it's not fatal. So it might seem like it's something that you're not super worried about, but it is important because patients stop taking their medication because of it. Also, as far as glucose and lipids, you want to make sure you monitor both, right? Monitor glucose and lipids as well as weight, especially with second-generation agents. QT prolongation. So the QT prolongation thing kind of depends on the med you're looking at. The overall risk of QT prolongation is low. So most of the drugs aren't associated with a lot of arrhythmias, except fluoridazine, has a high risk for QT prolongation and arrhythmias as a result. Where can I fit this? Ziprasidone and iloperidone are moderate risks. Okay, so fluoridazine, big deal for QT prolongation. So if you have a patient who already has arrhythmias, they're on some sort of drug that causes QT prolongation, you do not want to give them fluoridazine. Ziprasidone and iloperidone are moderate risk, so I would also use caution with those. The other agents aren't a big risk, so those would be preferable in those situations. Antipsychotic agents, all of the antipsychotic agents lower the seizure threshold. So caution in patients with seizure disorders or are at risk for seizures. One example of this is patients who are going through alcohol withdrawal. Alcohol abuse just happens to be higher, or people with schizophrenia are at higher risk for alcohol abuse for probably pretty obvious reasons. So when someone's withdrawing off of alcohol, they're at an increased risk for seizures. So that's something to be aware of if you're in an inpatient facility. If a patient's coming in due to some sort of a psychotic episode and they happen to be withdrawing from alcohol, and then you throw antipsychotic agents on that are going to lower the seizure threshold, it is important to look out for seizures. And in that case, you can do benzodiazepines. There's a whole host of other things that you would then do to monitor and be careful for the seizures. Also, caution in patients with mood disorders due to an increased risk of suicide. Caution in elderly patients with dementia-related psychosis. Trying to think what else. I think we covered all these: postural hypotension, sexual dysfunction, EPS, sedation. Yeah. These last two slides are just screenshots from the textbook. Goes through each of the drug and just some specific notes for that drug. Once you understand everything for the lecture, this page and the next one are really what would be most helpful when you're choosing an agent for your specific patient, because it goes through the specifics for each drug. So like aripiprazole, for example, low potential for EPS. Well, that's because it's a second generation agent. Low potential for weight gain. That's really good because weight gain can be a problem with these drugs. Low potential for sedation and antimuscarinic effects. That sounds really good, right? And that's one of the reasons why aripiprazole was one of them that I said is really commonly used. It's got low incidence of all of these adverse drug effects. And then you can see that we use it in multiple other conditions. It's also approved for bipolar. We use it for autistic disorder in children. It can be an adjunct for major depression. And look, there are 2 long-acting injectable formulations available that help with compliance. Right, so that would seem like a pretty good choice. Whereas if you look at something like clozapine, remember clozapine was one of those that we said had a lot of like adverse drug effects, so we only reserve it for very specific patients. But agranulocytosis, right, seizure risk, myocarditis, weight gain, there's all sorts of stuff with clozapine. And then this is just the remainder of the chart. Weight gain is, there's a lot of weight gain with quetiapine. Quetiapine was one of them that you always need to look out for weight gain with. trying to think what else. Olanzapine also has some kind of moderate to high weight gain. So I think these two are the ones where weight gain is the biggest issue, quetiapine and olanzapine. But I'll leave this for you guys to kind of go through and read all of the specifics for. All right, that is it for antipsychotics. The next video, guys, will be on anxiolytics and hypnotics. So we'll be talking about anxiety and sleep.